So hello everybody, and thank you very much for joining us again. Today, I would like to share with you a pre-recorded session with Dr. Dennis Bohr talking about dilatation of the eustachian tube, balloon dilatation of the eustachian tube. So Dr. Dennis hopefully will join us towards the end of the session to answer any questions that you have, but I think you'll find it very, very interesting. It has been increasingly applied in our day-to-day clinical practice. This was again recorded earlier, but hopefully again I'm expecting Dennis to show to come with us or to join us about 10 minutes to 6. So I'm going to start the sharing, and if you have any thoughts, please share them with me through the chat line. Thank you very much. Dennis, can you hear me?
Loud and clear, thank you.
That's great. Thank you very much for joining us. Good to see you.
It's good to see you, Muaz. Thank you so much for having me, and I really appreciate you putting together this lecture series for people.
Thank you. So Dennis, of course, is a world authority on eustachian tube, and recently he's been working on the dilatation of the eustachian tube, and we have asked him to share his experience with us, and you would love his lecture. He's always a great speaker, and he will make all his points to you a very clear way. Go ahead, Dennis, you have the podium.
Okay, well, thank you, Muaz. So I'm going to share my screen here. And you should be able to see that?
Absolutely.
Great. Let's see. Are you seeing all of these images on the side?
Yeah, everything is there.
Let's see. Trying to minimize that. There we go. Okay. Well, again, Muaz, thank you. And on the behalf of your institute, I greatly appreciate the educational opportunities that you've put together and innovating to do this at this time when there's so much lockdown and virus crisis going on worldwide. So thank you very much. We appreciate all the work you're doing. Thank you for inviting me to talk about the eustachian tube, and Muaz specifically asked to talk about updates on balloon dilation of the eustachian tube. So we'll speak about that. I'm a neurotologist. I'm based at the Boston Children's Hospital. I also take care of adults as well as needed. So that brings me into this. So a couple of disclosures. I am a consultant for one of the balloon companies, the one that I use here in the States. So I'm as a consultant, I help to design this, but they pay me just for time and expenses. I have no royalties from this. I don't have any equity interest in the company. So it's just so that I can be paid to work on the getting the work done. And this balloon is not approved for, neither of the balloons are approved for pediatric use in the US. So when I speak about pediatrics, that's off-label. Okay. So we'll talk first about the physiology of the eustachian tube. It's really, as an otologist, it's hard for me to come to the realization that it really is acting as another sinus, with the thinking of the middle ear and the mastoid as a sinus. But the eustachian tube is very different. It has a very long and dynamic ostium. It's controlled by a valve. And disorders of the eustachian tube are mostly about that valve. So here's a longitudinal section through a cadaver eustachian tube human. This is the nasopharyngeal orifice here at the 0 millimeter mark. We see it slowly tapers through the cartilaginous portion and gets narrowest just as it reaches the bony cartilaginous isthmus, which is about 25 millimeters. That's an important number to remember when we're working in the eustachian tube. The cartilaginous eustachian tube, about 25 millimeters in adults. And then we get to the what Muaz and he's convinced the rest of us, the bony portion of the eustachian tube is really just an extension of the middle ear space. And I appreciate Muaz's leadership work on making us think about the middle ear, the protympanum, merging with bony eustachian tube. There's actually no anatomical division here. And so you're absolutely right, Muaz, that this really is part of the contiguous middle ear space, and the functional valve that really differentiates the eustachian tube is here in that cartilaginous portion. So we know that the eustachian tube functions to maintain air ventilation. It clears fluids out of the middle ear, and it prevents reflux of pathogens, gastric contents, and also our voice and breathing sounds from getting to the ear in a patchless tube. The eustachian tube is actually much more curved than we think of. So this is important for surgeons. Now we can see an air contrast here in this cone beam axial multiplanar reconstructed eustachian tube, which is patchless. And so you can see an air column all the way to the middle ear. And there's a curvature here, even in this much more straighter than usual patchless tube. When you have inflammation, it's going to accentuate that curvature. And you have to be aware of that so you don't instrument it and cause a false passage, thinking you're getting into the lumen by going in straight. So here is how we look at the eustachian tube now, lining up our endoscope down the valve here. So kind of like as you do a laryngoscopy, you want to be looking down the length of the trachea through the larynx so that you can see how the vocal cords move. And this is the view that you want. Here is a right eustachian tube closed, and we see this bulge, which is the tissues of the anterolateral wall, including the cartilage that loops around. And it's the function of the eustachian tube to open that into a nice round opening. So that valve has to open to allow air to get through. And that's where we're going to be analyzing for most of this talk, looking at how that opens and maintains that aeration. The best way to look at that is with an angled view. Here are some right eustachian tubes. This is this is the torus. Here's the adenoid. The lumen is here. And with a 0-degree view, you frequently cannot see adequately the valve. You see the torus really well, but we don't see that anterolateral wall meeting the torus. And that's critical that's where the pathology is. So with an angled view, here's a 45-degree endoscope. You can do this with a 30-degree. Here we can see the folds of the valve closed. You can see both walls. And keep in mind that the eustachian tube tends to follow the anterolateral wall. The torus is quite variable. So the torus will not lead you easily to the lumen longitudinally of the eustachian tube. The anterolateral wall will do that. So how can we view that practically? You can use a 30-degree scope, 45. I actually mostly use the flexible endoscope. So here's how I do that. This is the left side. Here's the inferior turbinate. That's the left torus, adenoid. This is the vomer over here. So I'm going to turn the scope 90 degrees and flex it back and forth across the vomer. So now we're looking at the right torus tubarius. This is the lumen of the eustachian tube here. Now I don't like looking sideways, so we'll turn the scope, and so we can see now into the lumen here. We can see the valve just as well as you can with an angled rigid scope, just less resolution. So once in position, we'll have the patient vocalize ka, 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 and what that does is it elevates the palate and the levator, and it will immediately rotate the torus tubarius, opening up the valve in the first stage. That's like a scaffold, a stage against which the tensor veli palatini muscle here in the anterolateral wall can then fire and pull the valve open to that round position that you saw. So swallows will give us that 1-2 effort of the levator, then the tensor to open under normal circumstances, and yawns will give a maximal dilatory effort. And if you have them say, ah, sometimes that works better than a yawn. So swallows So first, ka to look just at the levator function, swallow to look at levator tensor, normal physiological movements, and then yawns and ahs for maximal dilatory efforts. So that's the exam that we do. Here is the, this is a 0 degree view of a left eustachian tube. There's the torus. You don't see the valve. Now you see the valve with this 45 degree view. So this is a normal patient. There's this bulge of this, of the tissues in the anterolateral wall. And there's a swallow in slow motion. Let's look at that in very slow motion. So the first thing you'll see is the palate coming up with the action of the levator muscle here in the floor. As it lifts up, it's going to immediately rotate the torus. It's going to hold the torus, against which now the tensor muscle is going to fire. There is the opening of the valve, and now it's going to close. So here's that levator muscle in the floor. It pulls up the torus, which is this medial cartilaginous lamina. Here is the lateral lamina that loops around and contributes to that bulge. And this is the tensor muscle, the tensor veli palatini in the anterolateral wall, which when it's relaxed, it has that bulge to it also. So we think now of eustachian tube dysfunction as a spectrum of disorders that occur with the valve. It's not just isolated diseases between obstructive and patulous. So on the one hand here, these are all left ears and their corresponding eustachian tubes. So this one is a Samter's triad patient. You see a lot of inflammation. It's swollen, edematous, lots of thick mucus. It never opens. And of course, this patient has an effusion. But if you have a lesser degree of inflammation, as you do here, we don't see the vessels well. It's edematous. There's little cobblestones. Those are follicular hyperplasia, adenoid-like tissue into the lumen. The lumen's edematous. So this tube can open sometimes, get some air in, and that's what you see here. Diffuse retraction, long-standing changes, and but it's not a medullary effusion. They're getting some air in there. And then if we have a lesser degree of inflammation, now here it's just confined to this band of inflammatory mucosa here in the floor. This patient's yawning right now, so you see the torus is medialized, and this is the only thing that's inflamed. We see the vessels very nicely. So this minimal degree of inflammation may be only causing problems when they're baro challenged, flights, diving, that sort of thing. They walk in your office with a normal looking ear, but they have a consistent complaint of baro challenge problems, and you can see that there is pathology here, just less of it on the spectrum. Now, particularly with allergic diseases, anything that causes atrophy of the mucosa, submucosa, the loss of fat, the Ostman's fat, or loss of the cartilage, the lateral cartilaginous lamina that normally bulges here, any of those things can give you a gap in the valve. And if it becomes longitudinal, the full length of that 25 millimeter cartilaginous tube, you can have a patulous eustachian tube. Now, particularly with allergies, they're prone to this patchy atrophy, but if their allergies become active again, they can start swelling up and become obstructed once again. But then when their disease is quiescent or perhaps they're over-medicated, that atrophy can start to open up and they can become patulous. And patients can go back and forth on this spectrum and fool you because every time they walk in your office, they're going to say, well, my ear's blocked. It feels full and pressure. They're not going to differentiate between these two, and they're going to make you think that they're always obstructed. So we have to be aware of this and be very cognizant of patulous. It's actually very common. It's far more common than we ever thought now that we're looking for it. So let's look at a few examples here. Here is a right eustachian tube. This is the torus here. It's swollen. You don't see vessels well, edema, lots of mucus. She's got allergic rhinitis. Now look at the adenoid. It's just barely touching the torus. But when she swallows, that adenoid is being pressed, or the pharyngeal constrictors are pressing this swollen torus into that adenoid, causing this anterior thrusting. And that anterior thrusting is closing this lumen, the valve, at the time it's supposed to be opening. This is very common, particularly with adenoid or tubal tonsil hypertrophy. Now contrast that to this patient, also an allergic patient. Torus is here, right side, and we see this bulbous, almost polypoid-looking edema. And yet when she opens up here with a yawn, you see this thin patch of atrophy here. That yellow color is the Ostman's fat. So we have this paradox of inflammation at the orifice in the nasopharynx from allergies, and yet patchy atrophy in the lumen. So this patient actually has a middle ear fusion, but if I overtreat her with a balloon, I could easily make her patchless. And many patients who look like this can become patchless even in spite of having inflammation at the orifice. So it's critically important to look into the valve to see what it looks like. You can't just trust what you see in the nasopharynx and at the orifice itself. You have to look deeper in the valve. Here's an example of adenoid hypertrophy in two cases. This one, 12-year-old boy, middle ear effusions. Here's his adenoid hypertrophy, right side. There's the torus, lots of inflammation. There's the lumen, and he's got pretty significant, that was a ka right there. Here's a swallow in slow motion, and what you see here is very significant anterior thrusting, slamming the door shut on the valve when it's supposed to be opening because of this adenoid hypertrophy, tubal tonsil hypertrophy. Now this patient, 15-year-old girl, has just as big a volume of adenoid hypertrophy. Here's her torus, but the geometry is different. There's a scaphoid defect in there, not defect, but a scaphoid shape to this adenoid. It's allowing the torus to fit into that, so she doesn't have the anterior thrusting, even though she's got a swollen torus. So she has no anterior thrusting. She's got a normal ear, but equal volume of adenoid hypertrophy. So it's not just about the size of the adenoid, it's how it's contacting the torus. And is it influencing it during this dynamic exam when you swallow or yawn? And so it's very important to have that view along the anterolateral wall, see the valve, and see what it's doing while they swallow and yawn. So we've talked a little bit about the patchless eustachian tube, what differentiates that. It's not just about an opening here at the orifice, but when they swallow and yawn, you see that gap in the defect go all the way as far as you can see. And in addition, they have excursions of the tympanic membrane with ipsilateral nasal breathing, so nose and mouth closed. They're sitting up, so their symptoms persist, and you can see some portion of their tympanic membrane, usually posterior or superior, moving with their breathing. Pathognomonic for patchless eustachian tube. So that's how we have to make that diagnosis. Just looking at the eustachian tube, you can see where the defect is, but this won't confirm. You can't see all the way to the isthmus, so you won't be able to confirm that that's the problem. This is the bottom line diagnosis. We tend to grade the degree of inflammation from 1 being normal to mild, starting to lose the contour of the vessels, no longer seeing vessels, moderate, and severe. The tube never opens. And I use these to differentiate how long am I going to blow up the balloon. So for lesser degrees of inflammation, I may only do a 1 minute or 1.5 minute dilation so I don't overdo it and make them patchless. So the degree of inflammation is important to decide up front how long you're going to blow up the balloon. So this is our checklist for eustachian tube dysfunction. The patients usually have oral fullness, they have hearing loss, along with when it gets full, they're baro challenged, they usually have had some middle ear effusion or acute otitis media, except for the baro challenge only patients. I always ask if they've experienced that their ear can pop with a nose blow or a modified Valsalva. If they say no, I teach them the modified Valsalva. So this is nose and mouth closed, gently, not forcefully, gently blowing, and then swallow at the same time. So it's more effective, and it is it's more effective than the standard Valsalva. and it is actually far safer. I've seen people experience permanent sensory neural hearing loss and vertigo with a forced Valsalva. So we teach them the modified Valsalva. The patient who needs surgery is usually unable to do this. If they can easily do it, there's some other problem. They could be patchless. They may have some other reason for oral fullness. Temporomandibular disorders are very common. So talking about Valsalva, very important during that visit. If they've ever had a myringotomy or a tube grommet, it should relieve their symptoms while it was functional. If not, it's another diagnosis. Again, could be patchless, TMD, other causes. A tube should relieve the negative pressure. Always ask about autophony. It's incredible how the patients don't always volunteer that. And if you don't ask, that you can really miss patchless. And this is one of the reasons it's been described as being rare. It's actually not just not rare. It's very common. If they have a tympanic membrane perforation, I always ask, have you ever tasted the drops? So if they can pop their ear with a modified Valsalva, or they're tasting drops, they've got some degree of patency, and that's a better prognosis. So we'll talk about assessing the phenotypes. We just talked about the history, and you'll confirm that history with your otoscopy. You're looking for retraction, middle ear effusion, and you can confirm these things on your tympanogram with negative pressure, flat tympanogram. We're looking for evidence of negative pressure on history and on our findings. And then we're going to correlate that with the endoscopic findings that I was just showing you. And I have this little mnemonic here where I look at the degree of mucus that's present, mucosal edema, swelling, erythema, lymphoid hyperplasia, these adenoid-like follicles going down into the lumen, which we see as cobblestones. And then how well does that valve open? And I call that a MELO assessment, so I don't forget to assess those points. So we're looking at all of those things while they do their swallows and yawns. This patient has a huge adenoid. It's practically burying the torus. Now, if we don't see pathology, there's no inflammation, we're not seeing a muscular problem, what else could be happening? Well, you have to think about bony eustachian tube lesions. And we've seen that in our series in about 10% of the patients with chronic eustachian tube dysfunction. And Muaz will gives lectures about how that number is probably increased in patients who've had chronic ear disease. And you can see that if you can get their middle ear aerated, if they have a perforation or you have a tube there, you can see that pathology as soft tissue density inside the bony eustachian tube. We talked about patchless, looking for the excursions of the tympanic membrane. Keep in mind temporomandibular disorders, not just the joint, temporomandibular joint disorders, but more commonly, it's problems with the muscles of mastication. They're tense, they're swollen, boggy, tender, and you can palpate that with a bimanual examination with your finger on the masseter and then in the pterygoid space between the ramus of the mandible and the maxilla. You can get your finger up there and feel for these boggy, extremely tender muscles in these patients. Watch out for the flaccid tympanic membrane or the acicular chain that might be loose. They'll have a conductive hearing loss and they'll pop their ear to try to make their hearing better. It's not a eustachian tube problem. They can easily do a Valsalva. They're trying to correct their hearing. So watch out. They'll fake you out, make you think there's a eustachian tube problem the way they describe it. And then you have to think about the inner ear disorders, superior semicircular canal dehiscence or other otic capsule dehiscences, high drops. They've got some very specific patterns to those as well that helps differentiate from eustachian tube problems. And migraines get blamed for everything. My friends want to add that on there just to make sure that they're not having ear pressure fullness from migraine disorders. So again, we're looking for pathology on the ear, consistent Barrow challenge and evidence of negative pressure either by history or on findings. This is a complicated slide. I don't have time to go through all of this right now, but those of you, you can take a screenshot of this. This is the algorithm that we use to differentiate these patients with oral pressure, fullness in their ear. So they have a retracted tympanic membrane. If they have a retracted tympanic membrane, it's usually straightforward. You can see negative pressure. You can measure it. They should have relief of their symptoms if they've had a tube, and you see pathology on the endoscopy. They've got typical obstructive dysfunction. That's what you would be, if they're not able to fix that with medical management. That would be a good candidate for surgery. The tympanic membrane, if it's normal, you have to think, well, it may just be a baro-challenged patient. In that case, you're still going to look for pathology on the endoscopy, and that patient may have obstructive dysfunction. The patients who have the autophony, you see the tympanic membrane breathing with the ipsilateral nasal breathing, opposite nostrils closed. That's a patulous eustachian tube. Obviously, we don't want to dilate those. Watch out for the patients who are sniffing so strongly that they give themselves a retracted TM. So those patients who we used to call habitual sniffers, they're actually inappropriately sniffing. They're sniffing, and yet they already have negative pressure. So watch out for those people. They're sniffing to close their eustachian tube valves because they're patulous. So they can mislead you because they'll walk in looking like a retracted drum. And so again, no baro challenge, autophony, TM excursions, tube didn't help. Think about those other disorders: temporomandibular, Miner's, semicircular canal syndrome, high drops. This is how you can measure patulous eustachian tube, not just by looking at the tympanic membrane, but you can measure that on the reflex decay mode. You can see the excursions with better sensitivity as they're doing that ipsilateral nasal breathing. Okay, I'm going to just go through a couple of cases here. Here's a 32-year-old male. He had tubes for miliary fusion as a child, outgrew it, but he's always had baro challenge problems with flights. He had an upper respiratory infection last year, and he has a persistent miliary effusion requiring a myringotomy. The myringotomy relieved the effusion at the time, but he's having increased baro challenge problems, and he has to fly a lot for his job, at least in the pre-COVID era. So remember, we've got to look at the whole picture. So here's his tympanic membrane. It's actually normal. Hearing is normal. Tympanograms are normal. But he's got that consistent history. Let's look at his eustachian tube. Here's his left side. So we see some mild inflammation here in the torus. You don't see the vessels terribly well. You do here on the anterolateral wall. Here is this boggy edema here on the floor of the eustachian tube. And you see it very well when he swallows and yawns like that. So the rest of the inflammation, rest of the lumen looks healthy. But that boggy tissue is probably the cause of his baro challenge. So he has minimal inflammation. You could treat this with a tube. He would do fine flying with a tube, but most of these people don't want a tube all the time. He's a perfect candidate for a balloon dilation, and that's what we did, a balloon dilation of the eustachian tube. And I only did 1 minute because you don't want to overdo it, and we just needed to crush this band right here, which was a relatively small amount of inflammation. And this is the most common thing you'll see with these baro challenge patients. Here's a second case, a 51-year-old male. He's obese, obstructive sleep apnea, former smoker. He only quit recently. And he's had sinusitis, but it's been controlled after 2 functional endoscopic sinus operations. He's consistently baro challenged. He gets miliary effusions after upper respiratory infections. He's had tympanostomy tubes twice in the past 5 years, and they do relieve the symptoms. So now he's back, ear fullness, hearing loss, which has persisted after an upper respiratory infection. So here's his exam. He's got miliary effusion. He has conductive hearing loss, as you'd expect. And we have negative pressures on the right, minus 330, and he's flat on the left, where he's got the effusion. So here's his endoscopic exam. Left side, here we see a big, thick, bulky torus. You don't see vessels. You get hints of cobblestoning here in this thickened swollen torus. Now, you're just seeing a mild amount of adenoid contact there. The anterolateral wall looks pretty good. You see vessels. So this inflammation is really here in the nasopharynx and here on the torus. So again, for demonstration purposes, we can look at this in slow motion. I don't normally do slow motion in the office. So here's his swallow. There goes the levator, and he's got very severe anterior thrusting. Completely closes the valve. So even though he doesn't have a lot of inflammation here on the anterolateral wall, he never opens his valve. He's a grade 4, severe. And so what can you do? He could get another set of tubes, or we could do a balloon. He didn't want more tubes per se, so we did the balloon dilation, but that's not enough. You have to treat whatever other inflammation is contributing here. So we did a adenoidectomy, including this lateral adenoid portion to get it completely off of the torus. We then debrided the medial half of the torus, taking off all this tubal tonsil tissue with a light cautery. I use the suction cautery at 15 watts. We don't cauterize on the luminal side. We don't want to cause scarring there. That's what the balloon is for. So the balloon is for the inflammatory tissue going into the lumen at this level. And he also needed his turbinates reduced, which we did all of that. So we're treating all of the pathology that was necessary, and he's done well. So there was a clinical consensus statement. This was put together over a couple of years and presented at the Academy last, let's see, it was 2018, and it was published in 2019. So there is now the American Academy of Otolaryngology consensus statement, which defined eustachian tube dysfunction. There hasn't been a good consensus definition previously. It's been universally accepted. And then we looked at the indications for balloon dilation and how to examine the patient. So I was privileged to be a part of this. It was led by Deb Tusi and Ed McCool. So the definition, as we've been talking, it's about failure to open the eustachian tube causing negative pressure. This study by Pau et al. From Germany, the investigators, the subjects, did not swallow or yawn for as long as they could take it, up to 2 hours. And then with a tympanometer in their ear, you can see in real time in humans how the negative pressure develops due to middle ear gas exchange. So by an hour, we're down to about a minus 100. By 2 hours, everybody quit. It was getting too painful. And they're down to about a minus 170. So you have to open your eustachian tube several times an hour to vent that pressure, or you build up an effusion or negative pressure, or you're baro challenged in flight. So evidence of negative pressure by history, by exam. You can measure it on a tympanogram. And if they're only baro challenged so that their ear is normal in the office, you still want to see pathology on the endoscopy like I showed you. There just will be less of it. Popping, clicking, these can mislead you. In fact, popping and clicking are much more common with patulous symptoms and temporomandibular disorders than an obstructed eustachian tube. Now watch out for this condition. This is a fixed pocket in a patient who has outgrown their eustachian tube trouble and now has a normal eustachian tube, an aerated middle ear, and a type A tympanogram. But this fixed pocket, once the tympanic membrane contacts middle ear mucosa, it can become fixed. There's upregulation of inflammatory mediators, and they can cause epithelial spreading, fibrotic attachment, bone erosion, progression of a pocket into a cholesteatoma, regardless of what the eustachian tube is doing. And Muaz will also talk about attic block as another mechanism. So you have to watch out for those conditions which are separate from eustachian tube disorders. So evaluate the eustachian tube independently of every fixed pocket may not have an active eustachian tube problem. So the indications for the procedure: chronic disease, you can see an effusion or non-fixed pocket. So we want to see negative evidence of negative pressure in the middle ear. You can measure it on tympanogram, and you're seeing the pathology on that endoscopy, that dynamic exam. Or if they don't have pathology at the time you see them, but they've got this barrow challenge, consistent history, you're still seeing pathology, just less of it. And so as surgeons, you want objective pathology that you're going to be treating. And that's what you're going to be looking for in the office. There's no one test that will give you the diagnosis of eustachian tube dysfunction. So it's this multidimensional evaluation, combination of that history, otoscopy, audiometry, tympanometry, and the nasal endoscopy exam. So by doing those things, you'll often see that there may be some underlying cause of the inflammation. And if you treat it appropriately, so we do a lot of allergy testing and referrals for testing and treatment, reflux, rhinosinusitis, etc. Many of these patients get better, particularly adults. So the majority of the patients who get referred to me for balloon dilation, I actually don't wind up operating on them. The majority of them get better with good medical treatment. The patient-reported symptom scales, there are a few of them out there now. The most common one is the ETDQ-7, the Eustachian Tube Dysfunction Questionnaire, 7 questions by Vijay Anand Ed McCool. And these are all symptom scores. They're not diagnostic scales. So they'll measure outcomes before and after treatment, but they will not differentiate between other causes of oral fullness. And people have made mistakes with that, trying to use it for diagnosis. You cannot. There's literature now that these scales will not differentiate between patulous temporomandibular disorders and obstructive eustachian tube dysfunction. So they're useful for measuring outcomes, and they're extremely sensitive for that. If you're using a balloon that is of a size that it can go into the bony eustachian tube, you want to make sure it's calibrated in some way. You're not going to go beyond that 25 millimeter mark. Now, all the devices have some safety measures on them, but the surgeons still want to be cognizant of not allowing the catheter to go beyond 25 millimeters into the lumen of the eustachian tube to avoid getting into the bony portion. That's where the internal carotid lies, and it can even be dehiscent into a eustachian tube. So most of the cases that we're doing, the pathology is not in the bony eustachian tube. You do not want a balloon to go up into that location. Keep in mind, if a tube does not help their symptoms, it's another diagnosis other than obstructive eustachian tube dysfunction. And that's a good bottom line test. All right, so we'll talk about the dilation itself. That part is simple. It's the diagnosis and the phenotypes that everybody struggles with. So this is not a new concept. Here was a paper from 1873 showing these bougie dilators. So people were doing this, but they were getting complications and they weren't helping. They were dilating the bony part of the eustachian tube specifically, and all of this was abandoned. So now that we've turned our attention to the cartilaginous portion, that's really made the difference. So here we see a right side. It's edematous, cobblestoning. There's inflammation here in the lumen. This is the inferior turbinate. It's on the right side. So the balloon is inside this angled guide catheter. We're going to point the catheter at the lumen of the eustachian tube, which is right there. This is the anterior pillar here, torus there. So we're just going to point it up to there, and the balloon follows the anterolateral wall, sliding in slowly. And they've all got a soft tip. All the balloons have a soft tip here that if you put it in slowly, you shouldn't get a false passage. Now this one is designed so you feel the isthmus, and when you feel the isthmus, there's a 31 millimeter safety marker here, a yellow marker. So we cross-check that. The balloon's in good position, make sure it's not kinked, and we blow up the balloon here, in this case for 2 minutes. Then we deflate it. There's that yellow marker. Then we'll deflate the balloon. And to avoid traumatizing the mucosa, we'll pull the balloon back into the guide catheter, keeping the guide in place so it doesn't scrape along. And then we'll look into the lumen afterwards to see what it's accomplished. And in this case, it opened it up a little bit there. And you notice there's no bleeding. I used to routinely see bleeding when I was using off-label sinus balloons. And in retrospect, now with these softer catheter tips that are bulbous, we're seeing very, very little blood unless there's really a lot of inflammation just from touching the kind of granular tissue. So I realized that we may have been getting mucosal tears and false passages way more commonly than we realized when we were using those off-label devices. So be cognizant of that. You really shouldn't be seeing a lot of blood. Now, frequently you won't see much change, and that's okay, because if there's a lot of inflammation, the pathology, the healing process is going to occur over about the next 4 to 6 weeks. This is what it looks like pre-op versus post-op. Here you can see, this is a year later. This is pre-op here. Bulbous edema, you don't see vessels, mucus, compromise of the opening. And post-op, we can see vessels now. There's still some, this edema is band here, but it's much more crisp. It's not as swollen. And the patient, when they swallow and yawn, opens much better than they did previously. So the balloon is effective in reducing inflammation. And we did histological studies to try to understand that. So pre-dilation, you see here, thickened epithelium, disorderly pseudocolumnar epithelium, loss of cilia. These are lymphoid follicles. Those are the adenoid-like tissue, the cobblestones that we see clinically. And then immediately after the dilation, it's stripped off a lot of that surface epithelium, but protecting the basal layer. So it looks good. You don't see a lot of excoriation. It's crushed the lymphoid follicles. And in the healing process, none of our pathology slides have shown a recurrence of the lymphoid follicles. And there's been restoration of the pseudocolumnar epithelium, and all of the cilia are back. So what we realized is that this balloon dilation is treating inflammation, in effect doing an adenoidectomy on adenoid-like tissue inside the lumen of the eustachian tube. So that's how I think about it now. We are now able to treat the adenoid-like tissue that gets into the cartilaginous portion in a safe manner. So eustachian tube dysfunction is not always, in fact, it's usually not in isolation. It's frequently associated with nasopharyngeal, nasal disease, allergies, rhinosinusitis, etc. So you have to treat all of the involved pathology that's relevant. And so if you see the inflammation going down the lumen of the eustachian tube and you want to clean that out, that's what the balloon will accomplish. So does it work? Well, there are randomized controlled trials now, and just briefly to show those to you. This was the first one that we did for the FDA approval in the States. So they were randomized between a control group where they only got nasal steroid sprays for 6 weeks after failing chronic treatment. They got randomized to that control group versus the balloon group, which also got nasal steroid spray for 6 weeks. So the big difference was the balloon. And we had 323 patients, 460 some ears. So tympanograms normalized. So the FDA required us to normalize, not just better, statistically significant improvement. We had to show that we could normalize it. So remember, these stats, you can have a happy patient with a minus 101 tympanogram. They may be completely asymptomatic, but for our study, that was a fail. So at 6 weeks, the balloon group, 51.8% were normalized. The steroid-only control group, 13.9%. And most of these patients wanted to cross over, so I can't show you long-term comparative results. But what we'll do is we'll follow the treatment group to see how they did. By 24 weeks, they're still holding up, in fact, a little bit better. And same results for the eustachian tube questionnaires. The symptom score is 56 versus 8.5%. And again, those results held up at the 24-week results. The statistics were so strongly significant that the FDA stopped the study early, which is very rare for a new device study, de novo device. So here's the 1 year follow-up, 57% normalized, and basically those numbers held up over time. Tympanogram normalization and eustachian tube questionnaire normalization held up over time at the 1 year point. So the other randomized controlled trial with a different device, the Entellus device, this group have a smaller group. They looked at tympanogram improvements here and improvements in the eustachian tube questionnaires, but the stats are very similar, 57 versus 10%. And this is at 1 year, 79%. Eustachian tube improvements, significant improvements, very little improvements in the control group, and those results held up by the end of the study at 1 year. And then they went on and did a long-term follow-up. So what you see here is the eustachian tube questionnaire results at baseline, and then at their 12-month follow-up, and then at the last follow-up, which had a mean of 29 months. And so all the indicators were significantly improved and maintained their improvement out to a mean of 29 months. These types of longer-term results are holding up in the various case series that have been out there. This is a group that I participated in from Finland, 2.5-year medium, and type A tympanograms, 79%. Schroeder, this is Holger Sudhoff's group in Germany. They were the first to be doing balloon dilations, and they've shown results out to 3 years, although their follow-up numbers dramatically decreased, but still quite consistent over time with 70 to 80% success. And then other systematic reviews, there have been a number. This is the biggest one, the Huysman study, significant improvement in all of the different things that they looked at, Valsalva's, otoscopy, tympanometry, eustachian tube scores. This is our study, again, a little bit better follow-up, 1.3 years, 79%. This was in Boston, 79% success. In Finland, another study, Lukainen, they had a mean of 3.1 years, 77%. And based on all of this data, the National Institute for Clinical Excellence in Health, the NICE organization in the UK, did a technological and systematic review, and they approved the device as of December. So this is now approved with the basically the indications that I showed you in our clinical consensus statement. So post-operatively, we have the patients avoid nose blowing for the first week to avoid subcutaneous emphysema and pneumomediastinum that has been reported. If you have a false passage, they start doing a modified Valsalva at about a week. So we want to get that air moving through the eustachian tube, and then hourly, I tell them hourly while awake, having them do it multiple times in the day if they'll do it, to see if they can start getting air through there. And that's that modified Valsalva that I told you earlier. Humidity if needed, and very important to keep the medical management going as indicated. So if they've got medical issues and they stop their long-term medical treatment, they can relapse. Patients with allergies can regrow their adenoid, and they can regrow the adenoid-like tissue in their eustachian tube. Complications, so you want to insert gently so that you don't lacerate the walls. You follow the anterolateral wall. That will help you avoid that. I talked about air emphysema just now. This is what can happen with a strong nose blow in the early post-op period. This was from Finland, even pneumomediastinum here. There have been very few of these cases, and they've all resolved without any complications. Patulous has been reported. We haven't had any permanent cases that needed treatment in my group, but I have had to treat some patients from elsewhere. The most common reason I've seen for this was an error in diagnosis. They had temporomandibular disorders, or they may have been patulous in the first place, and now they're worse. If you overpressurize, you could cause a tympanic membrane perforation. That's been reported. The most common reason for that would be a false passage. The balloon is occluding the eustachian tube lumen, and that back pressure is going up to the ear. The balloons have the balloons in the States have a lumen to vent air pressure to try to avoid that. This is the only synechia I've heard of, and this was asymptomatic. Hasn't been a pressure. Carotid injury, so we believe that there was a case, we don't have all of the details, but there may have been a case where a balloon did get into a bony eustachian tube and caused a very severe hemorrhage. We don't know the outcomes of that, but the surgeon did admit that a balloon got up into the bony eustachian tube, but they did not disclose what the outcomes were. So it's a strong reminder, we want to keep these balloons out of the bony eustachian tube. We're treating the cartilaginous portion. I'll just show you how you can get a false passage. This is a cadaver on the right side. So this is a balloon being inserted with a 0-degree endoscope, and we don't see the anterolateral wall. So just pushing it in there, now I'm meeting resistance. So let's take a look and see if we're in place. There's that yellow marker, so it didn't go in as far as it's supposed to. That's a false passage. So here's a 45-degree view to see what happened, what went wrong. If you follow the anterolateral wall, that's the lumen. So the balloon went here through a false passage, and this tissue is very thin. I've never, and look where that probe is. That probe is at the bottom of the apex of the fossa of Rosenmuller, right where the internal carotid artery is. So if you get a false passage like that, you're heading right for the internal carotid artery. Surgeons who've had a false passage never felt it, whether it was in the lab or actually if they had one during surgery. This is sufficiently thin. If you do this blindly, quickly, with force or pressure, you can pop right through that thin mucosa, and you will not recognize it unless you are looking for it. So go slowly, insert slowly, smoothly. It should feel like it's going through butter, and follow that anterolateral wall. This won't happen to you. I'm going to skip that one. And just to remind you, the patulous eustachian tubes are very common. These are all patulous eustachian tubes. They're retracted, they're adherent. Here we've got evidence of chronic ear disease, tympanosclerosis, and you can see the tympanic membrane moving here. This patient had cholesteatoma, and they're moving there. This one's got an active cholesteatoma. This one's not a video, but they're moving with ipsilateral nasal breathing. 25% of our patulous eustachian tubes look like this. They have evidence of chronic ear disease. So they can start off with obstructive disease. The retraction pockets can progress to cholesteatoma independent of what happens to the eustachian tube. So not every person with a cholesteatoma needs a balloon dilation. What they do need, every person needs an exam to see is the eustachian tube still a problem or not. I'm going to briefly mention pediatrics and then wind it up here. The Germans were the first to get into pediatric dilation. This is their balloon. And the results have been a little bit mixed, 75 to 80% in the first paper, 64% in a different group, not a follow, but a different cohort, same group with Tisch and Meyer, 80% improvement. And I'll just show you, these are results from studies that we've done. This group are all cases done at Children's Hospital with balloon dilation, so this is off-label. And this is a matched cohort study where we looked at patients who'd had previous tympanostomy tubes, and almost all had adenoidectomy, so they were case-controlled matched for age, sex, numbers of tubes, and adenoidectomy. And we looked to see how our balloon group did versus patients with the tympanostomy tubes only, and the patients with tympanostomy tubes kept getting more tubes with a large degree difference versus the balloon group, and with follow-up out to 2 years. And then a separate cohort, so these are patients by Dr. Mark Dean. This, by the way, has been accepted for publication recently. This group of patients operated by Dr. Dean, and then we took another cohort of control patients at Children's because we have such a huge database, and we matched controls here. And again, you see virtually the same kind of results. And he's got out to 5-year follow-up. So the balloon works in pediatrics. It is approved. The German balloon is approved for pediatrics. And it can really make a difference in the natural history of chronic eustachian tube dysfunction in pediatrics when used appropriately. So the lessons learned here, try to find the underlying causes of the pathology, treat them. The patients who don't get better, you know how to do that. You can place tympanostomy tubes. If they've got a middle ear effusion at the time you do a balloon, we also place a tube based on this RCT, randomized controlled trial from China, showing the results were a little better if you release that in fluid and negative pressure. So if they've got an effusion, I'll put a tube in. If they've got a partial effusion, I'll do a myringotomy. If they've got adenoid disease that's impinging on the torus, interfering with it, we'll take it off. We'll do a lateral adenoidectomy, pulling the adenoid tissue out of the fossa of Rosenmüller so I can cauterize it like you see here. You never cauterize into the fossa of Rosenmüller because that's where the carotid is. Light cautery of the tubal tonsil tissue, and then for adenoid tissue going into the balloon, adenoid-like tissue going into the lumen, that's what we treat with the balloon. Do whatever else is necessary to control the disease, surgically, medically, and this procedure can work for you. I want to invite everybody to our course, which we give every year, except this year. We would have been giving it right now. So you're all welcome. Next year, it'll be in May again. Dr. Kennedy will be our keynote speaker. So with that, Muaz, thank you again. And thank you to all of you for taking time out during this very busy crisis time to participate in these lectures. I'll stick around for some questions. Thank you.
Thank you, Dennis. This is a very. So I was I'm hoping that Dr. O will join us. However, I cannot really find them online. But if you really download the app and you could send me the questions through the app, I promise you I will relay them to Dr. Dennis Poe and make sure that you get the answer back. Thank you very much again for joining us, and hope to see you tomorrow. We're just 2 minutes before our end time. So thank you again, and have a nice evening.